Perfect, Sabrina.
Thank you. Good afternoon, I'm Sabrina. I practice at Sengkang General Hospital with a lovely team of colleagues, many of whom are kind of here online with us today. Thanks very much to ELSA and Ravi for giving this time to share thoughts on current issues in surgical safety at a time where most of us are actually considering what we hope to be a safe return to regular practice. And I think we've discussed quite extensively on this, how the hazard of smoke is just notoriously underestimated. And the concept of aerosolization theorizes the increased radius of dissemination, which makes us concerned in MIS. Taking a step back,
Sabrina, talk slowly because your voice breaks down.
Okay, got it. Is this better? Okay, so taking a step back, we are all aware that SARS-CoV-2 has established itself as not only a respiratory, but also an hepatobiliary pathogen, listed mainly in respiratory tract excretions, but also in feces and peritoneal fluid in at least one case. However, it is unclear if there's potential for transmission beyond respiratory droplet and its aerosolization. So aerosol generation procedures that are routinely encountered by dental surgeons and anesthetists include intubation, extubation, endoscopy, conventional, and minimally invasive surgery. And the concern that aerosolization of smoke, blood, abdominal, and GI content may increase the radius of viral dissemination is pretty real. So given this risk is real, we ask ourselves, really that high for us as general surgeons? And with respect to the experiences surrounding viral presence in peritoneal fluid, the literature really demonstrates both sides of the coin. Dr. Coccolini here shared with us that prior to his published positive case of SARS-CoV-2 in peritoneal fluid, his center sorted through at least 12 patients with negative peritoneal fluid samples before the 13th case positive sample came through. Meanwhile, in our own cases, we have negative 2 cases of COVID patients suffered appendicitis with base appendicolitis and gangrenous calculus cholecystitis.
Sabrina,
yes.
Your voice is kind of breaking off very frequently. Maybe take it a little easy. Just make sure you're in an internet zone that's okay. You're breaking very fast. Is that right? Carry on slowly. All right.
Can you hear me a bit better?
Yeah, it's very good now, Sabrina.
Okay, I'll try with the earplugs, so sorry about that.
Much better now, yeah, thank you.
Okay, so I was just sharing how Dr. Coccolini told us that his published positive case of SARS-CoV-2 in peritoneal fluid. Now, this was actually the 13th case, and prior to this, they had 12 patients who actually had negative samples. So in 2 of our experiences, COVID patients that had appendicitis with base appendiculis and gangrenous calculus cholecystitis, we actually had negative results. So with these limited numbers, we struggle to completely understand the factors that may influence positive rate. While bacterial translocation is a pretty well understood entity, the pathophysiology behind viral presence in peritoneal fluid is pretty elusive, and we postulate that perhaps duration and degree of obstruction or inflammation may influence degree of translocation or microspillage, influencing hence the viral presence in the reactive peritoneal fluid. So in breast surgical oncology, professional societies have led the unenviable challenge of clarifying guidelines on management prioritization for breast cancer during this pandemic. And so far, triage recommendations estimate the risk of delay-related outcome compromise based on stage and biology. Interventions range from reorganizing of treatment sequence, deferment or simplification of surgery, radiotherapy, and systemic therapy, to the use of purely neoadjuvant endocrine therapy in centers with more than significant constraints. And the common theme is really to delay whatever is possible. So based on overall limited experience, the risk of SARS-CoV-2 existing in peritoneal fluid cavity and other bodily fluids may really be low. The risk in soft tissue operations may even be negligible. No studies so far demonstrate or can suggest the ability of a virus to be transmitted during surgical treatment, whether open or MIS, and the theoretical risk for OT staff and surgeons for COVID patients may actually be lower than initially suspected. Additional advantages of MIS that Prof has gone through include containment during surgery within the predefined space decreased wound and pulmonary complications, shortened intensive care and hospital stay. So while the message overall remains that we be better safe than sorry, above all, I believe we all seek to maintain good standard of care and our ethical responsibility towards patients and colleagues when we make our surgical decisions. So I'm just going to take a short stroll with everyone through our SKH peri-pandemic experience. So like in most hospitals, our initial priority was resource optimization. And the key principles were firstly, clear hospital directives and communication channels for accurate, timely information dissemination. And this is pretty important in the volatile dynamic environment of an evolving pandemic. Secondly, to build surge capacity to balance COVID operational requirements and emergency services, but still continue time-sensitive semi-elective care as far as possible. And thirdly, mitigation of infectious threats to staff by initiating operational protocols, optimizing infrastructure, refreshing our PPE stores, doing hospital-wide refitting of N95 and PAPR, maximizing team segregation and telecommunication. And everyone in the hospital here wears RTLS tags that track staff to patient to location. So contact tracing is made easy. Like in most hospitals in Singapore, we are also part of resources. A lot of our resources also go invested into nationwide commitments towards stabilizing infection in the community. And one of these important lessons learned from our migrant worker dormitory operations was that ARI symptoms and clinical signs, such as fever, oxygen saturation, and heart rate, translated to low discriminatory value for SARS-CoV-2 positivity on nasopharyngeal swab. And again, this amplifies Prof's concern that not only COVID patients may have symptoms, but hints that our vigilance ought to be extended to include our asymptomatic, pre-symptomatic, false negative tested individuals, and well, basically everyone. So for our COVID patients and suspect cases, an experienced team that operates in the daytime as far as possible generally comprises of one consultant anesthetist, one anesthetic nurse, two specialist surgeons, and two senior scrub nurses. We try to avoid using OTTs. For the entire team, we meet for a brief before the patient is mobilized from the ward. We do strict droplet and direct contact precautions. We utilize goggles and hood and PAPR for the entire team down to the circulating nurse. Before the first COVID patient hit our shores, and most of our surgical department actually participated in full dress rehearsals, utilizing PAPR on real patient procedures in order to avoid eventual costly hiccups. So the patient experience is as such. We ensure clear surgical indications and counsel for procedures in the patient's best interest. Physical consent forms are completed and plastic sealed. The patients are then escorted by a private route by a security team, and the route to the OT is then cordoned off to avoid accidental walk-ins. PPE donning and more importantly doffing is strictly observed by our nursing sisters in charge. We have pressure-controlled operating theatres, and we're very lucky here. They consist of 4 interconnecting rooms with 2 anterooms, the induction and scrub, having lower atmospheric pressure than the operating room itself. And these are sealed by interlocking doors with airdrop seals. Our intubation extubation protocols allow only the anesthetic team in the OR, very much like NUH. It includes lockdown period of 5 minutes to allow for air exchanging of 2 exchanges and cleaning before the rest of the team enters. And required equipment and consumables are carefully selected and prepped and brought in. We minimize unnecessary traffic in and out, and post-procedure contained evacuation of pneumo and thorough cleaning is mandatory. So in line with these principles of a safe return, for the elective patient, most things would remain except that more applicable workflow may include patient risk stratification and appropriate testing, PPE that includes eye shields and N95 respirator for the surgeon. Our anesthetists still use PAPR in elective cases. So this is what my regular elective OT on Monday kind of looked like. But we also keep in mind context. The effectiveness of the healthcare professional's ability to manage business as usual medical issues is still heavily dependent on multiple factors, ranging from personal, professional bandwidth, availability of manpower, resources, and of course our country's infrastructure and capacity. So in our own breast unit, we mobilize a triple algorithm approach aimed at delivering optimal breast cancer management despite all these pandemic constraints. And now we've compared our women with breast carcinoma who presented during this peri-pandemic period versus similar months from January to April last year, where we were about 5 months old. So although we experienced about 50% decrease in new cases this year from March and April, there was a 27% decrease in cancer diagnosis that was deemed statistically insignificant. Although slightly more had T4 disease, patient characteristics, stage, and cancer biology was similar and reflective of the National Registry's distribution. We were also pleased to see no significant difference in duration from operation listing to surgery. Peri-pandemic, 74% of our patients had surgery within 1 week and the rest within 2, of course, possibly related to resource ring fencing. Of note, there was no significant difference in surgery type, including reconstruction and oncoplastic breast conserving surgery, for which unfortunately many other countries had to go without. The point I hope to raise here is that optimization and delivery of gold standard management ought to be looked into whenever possible so that we can minimize the post-pandemic tsunami of backlog cases and the relevant collateral damage that results. And such reflection really helps us mold our subsequent steps and can streamline future approaches for emergency response preparedness. Well, guidelines are rightfully tough, but should accommodate individualized considerations for patient and systemic factors unique to our practicing environment. So moving forward and back to our theme, the guidelines, of course, have unanimously recommended smoke evacuator devices with formal suction and filtration systems. So I'm just going to take another minute to remind us of its usefulness, both in conventional and minimally invasive surgery. So here, we'd be surprised how much plume can be redirected just by using a handheld evacuation device. And if you keep a close watch right about here, you can see that most of the smoke is actually rapidly inhaled by the pencil. So this particular electrosurgical pencil is extendable, courtesy of Abe. Nice for tunneling soft tissue, and it goes out a lot further than that. So I imagine it would be pretty nifty in the pelvis. And since smoke evacuator usage in lab and robotic has been really well discussed by Mr. Asim, I'm going to demonstrate how we can maintain the intermittent smoke evacuation while using the endoscope during breast MIS procedures. So the setup is really simple. Much like laparoscopy and robotic surgery, we connect the tubing to the endoscope itself and the end to the pre-filter and the filter. So here, the surgical assistant manually generates the low intermittent suction by occluding the button. So when gas insufflation is utilized for the anterior flap, the same tubing can just simply be connected into the trocar as per standard MIS. So bear in mind though, if we do excessive or continuous suction, it can collapse the surgical field. So in essence, I use low suction pressure and titrate that to preference. There is a short learning curve for the assistant to correlate the digital pressure to the suction intensity. And of course, we can consider a self-constructed wound retractor glove port, which is relatively more affordable, to ensure a closed system for the pandemic itself. And alternatives just include the regular standard suction tubing. But bear in mind, the main difference is that that generates continuous suction unless that tube is occluded. So precision may differ somewhat. So in conclusion, to clear the air, I believe we should save and be safe. But we try not to delay the inevitable and do bring these practices and lessons into the routine as future. Thank you very much. I'll be happy to take any questions in Q&A.